So moving next, we have the last case for today's presentation, and this is a case of squamous cell carcinoma of the esophagus with a severe dysphagia. And the case will be presented by Dr. Suzanne Gisbertz, an upper GI surgeon from the University Medical Center, Amsterdam. Dr. Suzanne, the screen is yours, please.
Thank you very much. I have a last case, hopefully not too long anymore. This patient was referred to our GEOCA center. That's the Gastrointestinal Oncologic Center in Amsterdam, where we have a patient-centered process with one-day diagnostics, a multidisciplinary team meeting, and where patients meet all the specialists that will be treating them. This patient was a male, 63 years old. He had a medical history of peripheral arterial occlusive disease and COPD with a FEV1 of 2.7 liters. He was a current smoker. He had 5 kilograms of weight loss with a BMI of 18 and very severe dysphagia and was unable to even swallow saliva. When we saw him first, he was already on tube feeding. And he was part of the day in bed, but when he came to us, he was very motivated and ready to change his lifestyle. So this was the upper GI endoscopy, showed a tumor from 22 to 26 centimeters. It was only possible to passage with the XP scope. And there was a second lesion at 34 to 36 centimeters. We took biopsies and he was put on tube feeding. This is the CT scan. It showed FDG avid tumor in the proximal esophagus, probably T3, and lymph node metastasis, 1 paratracheal right and 2 on the left side. No distant metastasis, and the second lesion was not visible on the PET-CT scan. There was also some pleural effusion, which was punctured twice and did not show any signs of malignant cells. And this is just one more image of the tumor and the lymph node metastasis here on the right side of the trachea. Here the tumor and the 2 lymph node metastases on the left side. So the diagnosis was the CT3N2 M0 proximal thoracic squamous cell carcinoma with a differentiation poorly differentiated, and the second lesion T2, also squamous cell cancer. So this is the question for you. What therapy would you consider? Definite chemoradiotherapy, neoadjuvant chemoradiotherapy, and esophagectomy. Esophagectomy only, neoadjuvant chemotherapy, and esophagectomy, palliative chemotherapy, or palliative treatment such as a stent or a radiotherapy to treat dysphagia. Can we have the poll question? All right. We have to answer a little bit later. Also in our MDT, there was quite a lot of discussion. Maybe better for this patient would be definite chemoradiotherapy because he was not in a very good condition to undergo surgery. However, probably this would not treat his severe stenosis, and he would still not be able to eat. So eventually we decided to try to optimize his condition and operate him after neoadjuvant chemoradiotherapy. So this was the radiation field that included both tumors. The prehabilitation was, of course, the feeding under guidance of a dietitian, physiotherapy with exercises at home and in a physiotherapy clinic. The smoking cessation with the aid of the general practitioner. We used to have an outpatient clinic for this, a lifestyle outpatient clinic, but because of the economics, it was stopped, unfortunately. The patient went to the pulmonologist to optimize his pulmonary function, and this all was strictly coordinated and followed up by the GEOCA nurse and specialist and the oncology nurse, because this is what you need to achieve some results. This was the restaging PET-CT, so the lymph node on the right side was still visible and the tumor as well, but the lymph nodes on the left side of the trachea showed response. and also the pleural effusion was gone. Whether this is a good sign or a sign of the cancer, we are not sure, of course. This is just a very short clip of the operation where you see the left recurrent laryngeal nerve. This was a robotic case, and we did a transthoracic esophagectomy with cervical anastomosis. And our ERAS protocol, the first time it was introduced was in 2009, and after which it was evaluated after 19 months, and it showed shorter admittance time and also of earlier mobilization, especially. Since then, there were a lot of adaptations. It is a really live protocol. It changes every half year or something. We add or remove something. And this is especially because we learned from others. We visit other clinics, like we went with the whole team to Don Low in Seattle, but we also went to Padova and to London. And we evaluate our protocol every 6 months with the whole team, which parameters work, which don't. And also what Don already mentioned, that auditing of this is very important. Just some highlights of the protocol. We use no sedatives, goal-directed therapy, the paravertebral catheter we learned from Ed. Early mobilization is key, early feeding via jejunostomy and immediate drinking. And we remove the gastric tube on day 3 if there's passage of contrast through the pylorus, which we learned from Don. And what is also very a nice additive is that we have rooming in available for a family member. So one family member is allowed to stay the whole admittance, and also helps with the taking care of the patients, and already learns some of the things they need to do at home, like taking care of the feeding, just jejunostomy, or the fraxiparin injections. And we also have like a breakfast buffet, so patients don't stay in the room for the breakfast if they are already allowed to eat, but they go have breakfast together in a room especially for that. This patient had a high CRP on D5. There was not a clear focus on CT, and the cultures were negative, but sometimes you see this also after radiotherapy. Happily, this was quite mild, and we treated him with antibiotics without a true bacteria we cultured for 5 days, and he was discharged on the 10th day. And not all parameters were met according to the protocol, but still he was discharged quite soon. And pathology results showed T3 and 2, with 4 of the lymph nodes were positive. A radical resection, Mandar 4, but in the lymph nodes there were signs of regression, so the radiotherapy still did something. And he's now 6 months after surgery and no evidence of disease yet, but we know this is a high-risk tumor for recurrence. So we will see in the near future what happens. Hopefully he will remain disease-free. Thank you.
That's a great presentation, Susan. I think we have time for quick questions. So for you, Susan, the first question is, do you use CT PET routinely in every patient?
Yes, we do. At first, when PET just came available, we did it only after the chemoradiotherapy for the restaging, but now we do it both before and after the neoadjuvant treatment. Yeah.
Another question is for Dr. Norkia. Is it necessary to repeat the pulmonary function test following the prehabilitation?
I'm not sure that it makes much difference. It might sort of make you feel a bit better about yourself, but unfortunately, this case, when you have a successful outcome in somebody with fairly terrible parameters, it might make you a bit more gung-ho. But I think the important thing is probably having an all-round picture of exercise capacity. This patient's exercise tolerance actually wasn't bad with being able to manage stairs, and so the FEV1 was deceptively low, possibly. So I think it's an all-round picture rather than, and doing it again, you know, what do you prove with it? You've either got to make a decision, do we go ahead? These are the risks, and you've got to be careful and keep a close eye after, I suppose.
The question is, what do you think about routine microtracheostomy for the patient with COPD?
If that's for me as well. So Minitrack, we used to use Minitrack for thoracic patients in our hospital up until about 7 or 8 years ago. And unfortunately, they're more of a sort of a cough stimulator and a throat tickler than they are of any benefit in suctioning secretions. And there were some issues with them on the wards and things, and so we went away from these. In this particular case, Ed, Cheong and I did have a discussion about possible tracheostomy and secretion management, but held off, and in retrospect, it proved to be the right decision.
I think I can ask one question to Edward. I think we were discussing stair climbing test to screen a patient in the clinic. Maybe your thoughts?
Screening the patient in terms of fitness?
Yeah, stair climbing, yeah.
So it's very common that we walk the patient. So you walk them at the time of the first clinic, walk them up 2 floors. So they have to get up 2 floors. I know I spoke to Miguel Cuesta. He said he walks them 1 floor. But I walk them 2 floors, and if they can do it in under a minute, and they're still talking at the top of the stairs in complete sentences, I think you got a good chance. It's not just about the physiological status and the respiratory or cardiovascular status, but it's also looking at the patient's determination to do it. So it's a whole round package. It's not just walking up there. And you can quickly figure out if the patient is not going to be keen to help you, or the patient is not going to be keen to do anything, or the restrictions of walking is because of osteoarthritis of the knee, etc., etc. So it's not just cardiovascular, So there are different things, and some of them, the first clinic, it's too much to do too many things, so we get them back again. So there are limitations for CPACs or pulmonary function tests as well. You need the whole package. You really need to see their physiological reserve, their mental status, and all that. Because some patients just do not want to go through with an 8-hour-long operation, having chemoradiation therapy. It's just too much for them, physiologically and mentally. I hope that answers the question. It's not just a number game. You can't sometimes put a number on it. There is some subjectiveness, but I walk them 2 floors. Yeah.
We did a recent study where we compared some of the risk models with the judgment of the surgeon. It's not published yet, but we found that the judgment of the surgeon is slightly better than the risk model. So that's really good to know. So it's important to see your patients yourself, and like what Ed says, take them for a walk or see them several times if you have doubts, or try first to give them physiotherapy, feeding, and see them again and again if necessary before you make your definite call.
I totally agree with that.
One last question for the end. Are patients with cirrhosis excluded from the ERAS?
No, definitely they're not. So it depends on what your classification of cirrhosis is. So we've done high-risk cirrhotic patients, but they got to be Child-Pugh A. I mean, if you got Child-Pugh B and C, then you're in trouble. So we don't go down that route. And the Child-Pugh A, you got to have a good reserve. What I learned from that is they don't tolerate post-op chemotherapies. So you get 1 chance: surgery, chemotherapy, then surgery, or straight to surgery, and you give it your best chance. So these are not training cases. These are cases for the experienced surgeons to do, because you only got 1 chance. And then after that, they take time to recover from surgery, and they're not user friendly in terms of putting them through post-op chemotherapy. And they will end up with liver failure, renal failure, multi-organ failure if you head down that route. So they take a longer time, yes, but they are very determined, yes, and they will come through. But they won't tolerate a lot of abuse, if you like, physiologically. I don't know, what's your opinion, Don, about cirrhotic patients? Oh, you're muted.
My opinion is, as you've inferred, Ed, they have to be looked at as individuals. There's multiple levels of cirrhosis. Someone who's in end-stage liver failure clearly is not a candidate for anything, including even definitive radiation chemo. I will share with you that we have done a couple of people with level A, B cirrhosis, and what we look for preoperatively is to ensure that they don't have an accessory, or more importantly, a replaced left hepatic artery, because those are typically sacrificed when you do your conduit. And if you have someone with borderline liver function and they have especially a replaced left hepatic, then you have to take that into account, and you have to do a lymph node dissection that facilitates maintaining that left artery, or you will put them into liver failure. So if you're looking to assess the aspects of the cirrhotic, it's not just the level of cirrhosis and your ability to do an operation that's controlled, does not require blood, does not require excessive fluid, but also to understand the anatomy as well.
Very good point. Thank you.
Another question, I think it's a more technical one. Take on thoracic duct preservation or resection.
We always resect it, unblock with the specimen. I don't know what the others do with.
Dr. Long?
Sorry, Misha, I'm interested in what you have to say, but we do not typically resect it. Suzanne and I have discussed this over a cocktail on several occasions, and the truth of the matter is that if there's multiple level involvement of main thoracic duct lymph nodes, we think that that is in a prognostic sense a profoundly difficult scenario. So typically what we will do a comprehensive thoracic dissection that does not involve resection of the thoracic duct, although we do not hesitate to take it if cancer-related issues has the main tumor mass closely associated with it.
We resect it in 80% of cases, 20%. Sometimes the duct is really high up near the aorta. Sometimes it's a tumor which is very distally, and then we don't believe that it's necessary to take all these lymph nodes.
Can I ask Misha a question? Misha, the nutrient trial is a really important issue, and getting this sorted out in an evidence-based fashion is obviously going to be very helpful. We note that, as is the case in many centers, the incidence of an anastomotic leak is not negligible in this scenario. And obviously, the initiation of oral nutrition is a complex issue in someone who has an anastomotic concern. Do you routinely do anything to assess anastomotic integrity as you're initiating your oral protocols?
Yeah, what we do is we measure CRP levels, and when they are not going down at day 4, we do additional analysis, but most of the time first CT scan, and if you see air around the anastomosis, any air, that's not good, and we do an endoscopy. And then, yeah, in the last, I think 3 years, we didn't have a great C leakage, so we didn't do a rethoracoscopy or something like that. Most of the time, it was just handled with a small suctioning tube and then cessation of oral nutrition. But yeah, we don't pick patients for starting the oral intake. We are, however, more careful with cervical anastomosis. So all the data I've shown you is on intrathoracic anastomosis.
Thank you.
So I think we are right on time, and it was very encouraging that we have close to 320 participations registered, and many of them were live today. And my heartfelt thanks to all our speakers and my fellow chairs for their contribution to today's excellent presentation. Thanks to everyone who has taken the time to join us online and in their busy schedule and actually participating in poll and question and answer session. We hope you found this presentation interesting and engaging. A few last minute announcements before we wrap up this session. The recording of today's webinar will be made available in the next week, and you will be notified when they are posted. There will be a link to a feedback survey when you leave the presentation. I encourage you all to leave a comment about today's session and other topics you would still like to see in the future. And that's all from my side. Thank you, everyone, once again. Stay safe. See you soon.
Thank you, all. And I have to especially thank Leah, Natasha, Amanda, Sanj, and as well as all the speakers today. You were excellent. Thank you so much. We learned so much. We had so much fun. Thank you. One other person I would like to thank is Simon Law for pushing us to do this. Thank you, Simon. Thank you. Once again, I hope to see you guys soon in person.
I enjoyed it very much. I learned a lot myself. Thank you very much for the wonderful lecture.
Yeah.
Have a nice day.
Thank you very much, everybody.